The patient with a headache. A tension headache is the most common headache, and yet it is not well understood. It generally produces a diffuse, usually mild to moderate pain over the front of the head. Many people liken the feeling to having a tight band around their head. A tension headache may also cause pain in the back of the neck and at the base of the skull. In its most extensive form, the pain feels like a hooded cape that drapes down over the shoulder. The headache is usually described as mild to moderately intense. A tension headache can last from 30 minutes to an entire week. Some experiences cause headaches only occasionally or nearly all the time. If the headache occurs 15 or more days a month for at least 3 months, they're considered chronic. If the headaches occur fewer than 15 times in a month, then the headaches are considered episodic. However, people with frequent episodic headaches are at a higher risk of developing chronic headaches. Some people with tension headache experience neck or jaw discomfort. While physical activity typically aggravates migraine pain, it does not make tension headache pain any worse. A few people with tension headache experience an increased sensitivity to light or sound, but this is not a common symptom. As the nurse, get a description of the type of pain, including its severity, location, frequency, and duration, and any other signs and symptoms. A CT/MRI are done to rule out tumors or aneurysms. Have the patient keep a headache calendar for at least 2 months. Write down a description of the pain, including how severe it is, where it is located, and how long it lasts. Tell the patient to note any medication they have taken. Each time they get a headache, jot down a description of the pain, including how severe it is, where it is located, and how long it lasts. Also note any medications that were recently taken. A headache calendar can offer valuable clues to diagnose the particular kind of headache and discover possible headache triggers. Analgesics. Usually the first choice is acetaminophen for tension headaches. If this proves ineffective, then nonsteroidals are the next line of treatment for reducing headache pain, like over-the-counter aspirin, ibuprofen, and naproxen. Prescription of nonsteroidals would include indomethacin and toradol. Combination medications like aspirin or acetaminophen are both often combined with caffeine or a sedative drug in a single medication. For example, Excedrin combines aspirin, acetaminophen, and caffeine. Pain medications don't cure headaches, they just relieve the symptoms temporarily. Benzodiazepine, butalbital combinations, and narcotics such as codeine and oxycodone should be avoided because these medications could become habit-forming or addictive. Overuse of these medications or the daily use of over-the-counter pain-relieving medications can cause analgesic rebound headaches. Preventive medications. Tricyclic antidepressants, including amitriptyline and noramitriptyline, are the most commonly used medications to prevent tension headaches. They're effective against both the episodic and chronic forms. Side effects of these medications may include weight gain, drowsiness, and dry mouth. Other medications that may prevent tension headache include anticonvulsants such as topiramate or gabapentin, and muscle relaxants such as tizanidine. Preventive medications may require several weeks or more to build up in the nervous system before they take effect. It's important to tell the patient not to get frustrated if they haven't seen improvement shortly after beginning taking the drug. It may take a couple of months or longer. Also, be aware that overusing caffeine or painkillers for acute relief may reduce the effect of a preventive drug. Clinical symptoms of migraine is moderate to severe pain, which may be confined to one side of the head or may affect both sides. Headache is described as steady, throbbing that matches with the pulse. Nausea with or without vomiting. Sensitivity to light and sound. During a headache, some patients hibernate and seek shelter from noise, light, odors, people, and problems. Migraines have a tendency to run in families. 4 out of 5 migraine sufferers have a family history of migraines. If one parent has a history of migraines, the child has a 50% chance of developing migraines, and if both parents have a history of migraine, the risk jumps to 75%. Sensitivity to specific chemicals and preservative in foods, like certain foods and beverages such as aged cheese, alcoholic beverages, beer, and red wine. Food additives such as nitrates, which you see in pepperoni, hot dogs, and luncheon meats, and monosodium glutamate, commonly found in Chinese food, may be responsible for triggering up to 30% of migraines. Excessive caffeine consumption or withdrawal from caffeine can cause a headache when the caffeine level abruptly drops. The blood vessels seem to become sensitized to caffeine, and when caffeine is not ingested, a headache may occur. Caffeine itself is often helpful in treating acute migraine attacks. Emotional stress is one of the most common triggers of migraine headache. Migraine sufferers generally are highly affected by stressful events. During the stressful events, certain chemicals in the brain are released to combat the situation, known as the flight or fight response. The release of these chemicals can provoke vascular changes that can cause a migraine. Repressed emotions surrounding stress, such as anxiety, worry, excitement, and fatigue, can cause muscle tension, and dilated blood vessels can intensify the severity of the migraine. Sensory stimuli. Bright lights and sun glare can produce migraines, as can loud sounds. Unusual smells, including pleasant scents such as perfume and unpleasant odors such as paint thinner and secondhand smoke, can also trigger migraines. Changing weather conditions, storm fronts, barometric pressure changes, strong winds, or changes in altitude can be a cause of migraine headaches. In some cases, these painful headaches are preceded or accompanied by a sensory warning, an aura, like flashes of light, blind spots, or tingling in the arm or leg. The auras can affect the other senses and are described simply as having a funny feeling. Other auras may include ringing in the ears, tinnitus, or having changes in smell, such as strained odors, taste, or touch. A migraine is also accompanied by other signs and symptoms such as nausea, vomiting, and extreme sensitivity to light and sound. The migraine pain can be excruciating and may incapacitate for hours or even days. The exact causes of migraines are unknown, although they are related to changes in the brain as well as genetic causes. People with migraines may inherit the tendency to be affected by certain migraine triggers such as fatigue, bright lights, and weather changes. There is a migraine pain center or generator in the midbrain area, and a migraine begins when hyperactive nerve cells send out impulses to the blood vessels, causing vasoconstriction, followed by the dilation of these vessels and the release of prostaglandins, serotonin, and other inflammatory substances that cause the pulsation to be painful. Certain brain cells that use serotonin as a messenger are involved in controlling mood, attention, sleep, and pain. This may be the reason why chronic changes in serotonin can lead to anxiety, panic disorder, and depression. CT. This imaging procedure uses a series of computer-directed X-rays that provide a cross-sectional view of the brain. This helps diagnose tumors, infections, and other possible medical problems that may be causing the headaches. A CT scan is a more sensitive imaging technique than X-ray, allowing high definition of not only the bony structures but also the soft tissue. Clear images of organs and structures such as the brain, muscles, joints, veins, and arteries, as well as tumors and hemorrhages, may be obtained with and without the injection of contrast dye. The MRI uses radio waves and a magnet to produce very detailed cross-sectional views of the brain. The MRI helps diagnose tumors, strokes, aneurysm, neurological diseases, and other brain abnormalities. An MRI can also be used to examine blood vessels that supply the brain. Mainly the diagnosis is based off the medical history and physical exam, but if the headaches are unusual, severe, or sudden, then the other tests are ordered to rule out other possible causes for headache pain. Spinal tap lumbar puncture. This is done for a possible underlying condition such as meningitis, which is an inflammation of the meninges and the cerebral spinal fluid surrounding the brain and spinal cord. In this procedure, a thin needle is inserted between two vertebrae in the lower back to extract a sample of CSF for laboratory analysis. Rare causes of headache include brain aneurysm, a weakening of the wall of the blood vessels that can rupture and bleed into the brain tumor, stroke, or TIA. If a patient is over 50 and experiencing headaches for the first time, they may have temporal arteritis. Symptoms of this condition include impaired vision, pain aggravated by chewing, and there is a risk a patient could become blind by this condition. Remember that a lumbar puncture should not be done in the presence of high intracranial pressure. Pain-relieving medications are designed to stop symptoms that have already begun and should be taken at the first sign of a migraine attack. Over-the-counter medications are effective for some people with migraines, especially when the migraine is mild. The main ingredient in pain-relieving medications are ibuprofen, aspirin, acetaminophen, naproxen, and caffeine. Patient education is important because sometimes over-the-counter medication can contribute to a headache or their overuse can cause analgesic rebound headaches or a dependency problem. Other medications are primarily given to treat the symptoms of migraine, can be used alone or in combination, and these drugs can reduce pain, nausea, or emotional distress. Medications in this group include nonsteroidal anti-inflammatory drugs such as ibuprofen, triptans like Imitrex, ergos such as dihydroergotamine or ergotamine with caffeine, Capregot. A patient may be a candidate for preventive therapy if they have 2 or more debilitating attacks a month, if pain-relieving medications are not helping, or if their migraine signs and symptoms include a prolonged aura or numbness and weakness. Preventive medications can reduce the frequency, severity, and length of migraines and may increase the effectiveness of symptom-relieving medicines used during a migraine attack. Cardiovascular drugs, beta blockers, commonly used to treat high blood pressure and coronary artery disease and can reduce the frequency and severity of the migraines. These drugs are considered among the first-line treatment agents. Calcium channel blockers, especially verapamil, also may be helpful in preventing migraines. In addition, the antihypertensive medication lisinopril and condensartan are used to reduce the length and severity of migraines. Antidepressants are most effective are tricyclic antidepressants such as amitriptyline, nortriptyline, or protriptyline. These medications are considered among first-line treatment agents and may reduce migraines by affecting the level of serotonin and other brain chemicals. Anti-seizure drugs such as dalvalprox, topiramate, and gabapentin seem to reduce the frequency of migraines. In high doses, however, these anti-seizure drugs may cause side effects such as nausea and vomiting, diarrhea, cramps, hair loss, and dizziness. Cyproheptadine is an antihistamine specifically affecting the serotonin activity. Botulinum toxin, Botox, is sometimes used for treatment of chronic migraines. Studies have had mixed results with respect to effectiveness. Injections are made in muscles of the forehead and neck. When this is effective, the treatment typically needs to be repeated every 3 months. Cluster headaches are a rare form of headaches as one of the most painful types of headache, characterized by repeated headaches that occur for weeks or months at a time, followed by periods of remission. It has also been called the suicide headache because many people have taken their lives either during an attack or in anticipation of an attack. The trigeminal nerve is implicated and is one of the most severe forms of headache pain. A striking feature of cluster headaches is that when the attacks occur in cyclical patterns or clusters, which gives the condition its name. Bouts of frequent attacks and what's known as cluster periods may last from weeks to months, followed by remission periods when the headache attack stops completely. The pattern varies from person to person, but most people have one cluster period a year. Fortunately, cluster headaches are rare, and this condition is more common in men. Cluster headaches are thought to involve dysfunction of intracranial blood vessels, the sympathetic nervous system, and pain modulation system. Genetic component has been noted in some families. The pain of cluster headache is almost always one-sided, and during a headache period, the pain remains on the same side. When a new headache period starts, it rarely occurs on the opposite side. The pain of cluster headache is generally very intense and severe, and is often described as having a burning or piercing quality. It may be throbbing or constant. The pain is so intense that most cluster headache sufferers cannot sit still and often pace during an attack. The pain is located behind one eye or in the eye region without changing sides, and may radiate to the forehead, temple, nose, cheek, or upper gum on the affected side. The scalp may be tender, and the pulsing in the arteries often can be felt. The pain of a cluster headache can last anywhere from a few minutes to 3 hours. The headache will disappear only to reoccur later that day. Typically, in between attacks, people with cluster headaches are headache-free. The most successful treatment are sumatriptan injections or nasal spray and oxygen inhalation therapy, 100% oxygen delivered by face mask for 15 to 20 minutes. Oxygen inhalation by facial mask can be used as a first sign of a cluster attack and has been successful in shortening an acute cluster headache. Sumatriptan is not recommended if the patient has hypertension or ischemic heart disease. Zolmitriptan can be taken in nasal spray form for relief of cluster headache. This medication may be an option if the patient cannot tolerate other forms of fast-acting treatments. Dihydroergotamine is a medication derivative available in intravenous, injectable, and inhaler form. It is an effective pain reliever for some people with cluster headaches. The inhaler form of the drug works more slowly. Octreotide is an injectable synthetic version of the brain hormone somatostatin and is an effective treatment for cluster headache. Surgical intervention may be considered for people with chronic cluster headaches who have not been helped with standard therapy. Because of the brief duration of an attack, treatment of the headaches is difficult. Often the acute headache has disappeared before the patient arrives at the emergency department or the physician's office to receive treatment. Other medications used in the prevention of cluster headaches include calcium channel blockers, verapamil, lithium, difalprorex sodium, corticosteroids, or melatonin and topiramate. To treat people with frequent cluster headaches, a pacemaker-sized device that sends impulses via electrodes that is implanted over the occipital nerve has been found to reduce chronic headache pain in some people. Deep brain stimulation of the hypothalamus may provide relief for people with severe chronic cluster headaches. Headache pain results from the signals interacting among the brain, blood vessels, and surrounding nerves. During a headache, specific nerves of the blood vessels and head muscles are activated, sending pain signals to the brain. Patient and education teaching is try to avoid the headache triggers. If the patient is not sure what triggers the headaches, then keep in a headache diary. They will need to include details about every headache. When did it start? What were they doing at the time? What did they eat that day? How did they sleep the night before? What was their stress level? How long did the headache last? What, if anything, provided relief? Eventually, they may begin to see a pattern and be able to take steps to prevent future headaches. Avoid medication overuse. Taking headache medications, including over-the-counter medications, more than twice a week can actually increase the severity and frequency of headaches. Get enough sleep. The average adult needs 6 to 8 hours of sleep a night. It's best to go to bed and wake up at regular times. Don't skip meals. Start the day with a healthy breakfast. Eat lunch and dinner at about the same time every day. Avoid any food or drinks such as those containing caffeine that seem to trigger headaches. Exercise regularly. Regular physical activity can improve physical and mental well-being. Exercise also helps reduce stress. Give the patient options to choose activities they enjoy, such as walking, swimming, or cycling. But to avoid injury, they need to start slowly. Reduce stress. Stress is the most common trigger of chronic headaches. Simplify their schedule. Try to get organized. Plan ahead. Stay positive. Most headaches caused by stress end when the period of stress is over. Relax. Try yoga, meditation, or relaxation exercises. Set aside time to slow down. Listen to music, read a book, or take a hot bath. Reduce caffeine. While some headache medications include caffeine because it can be beneficial in reducing headache pain, it can also aggravate headaches. Have the patient minimize, or better yet, eliminate caffeine from their diet.